Oh, yes, yes. Good evening, sir. I think I'm audible and visible.
Yes, sir.
Okay, perfect, perfect. Let's start with the class, right? Yes, yes. Good evening, sir. I think I'm audible and visible.
Sir.
Okay, perfect. Hello. Echo आ रहा है. Is it okay right now? Voice is okay. And I hope the echo is not there now, right? So shall I
Cleared, sir.
start?
Cleared, cleared.
Okay, okay. So, good evening. Good evening, everyone. This side Dr. Abhijeet, and today, welcome to yet another session in the Exam Mastery Live classes, where I will be discussing the organ function test. I will be covering the organ function test today, right? So you already know this. This has been initiated from June 1, and the duration it is approximately like we're going to cover the entire thing in like 45 days. So yeah, guys, over here we are just discussing the important questions, right? In a very crisp, conceptual, and concise manner, right? In the form of Q&A, the question and answer format. Apart from that, all the important questions and all the previous year questions that are now important for the upcoming NEET PG exam and FMG exam are also being covered. So apart from that, like it is, you can just revise all the topics with me. Yes, so these are the questions that I will be covering up today. Yeah, these are again fact-based questions, right? So we have the long question answer and the short questions answer that is being displayed on the screen, and that's what I'm going to discuss with you guys today. Apart from that, guys, you already know the features of the Oracle app, right? So if you are unable to attend the class live, you can just go to the recorded classes that are available on the Oracle app. Apart from that, the notes that we are using during the live lectures, guys, they are actually curated in the form of Q&A, right? And after each section, guys, you will have these important MCQs, right? The multiple choice questions from basic to advanced level where all the previous year topics, previous year questions, and yeah, new clinical based questions will be covered, right? Integrated questions will be also there. So that is something which you can like look for. No, coming on to the subscription plan, guys, you can just see the subscription plan displayed on the screen. Apart from that, if you want some more additional discount, you can use my code Dr. Abhijeet 20 for the discount, right? So yes, let's start with the organ function test, and the very first important it is the LFT, the liver function test, right? Yesterday, guys, I was discussing about the bilirubin part, right? No, no. I have already told you whenever the hemoglobin, okay, whenever the hemoglobin or the heme part of the hemoglobin, it is degraded, right? We have already discussed it yesterday. If it is degraded, guys, what it will form? It will form bilirubin, bilirubin, right? Now, guys, remember that bilirubin is a bile pigment, right? And it is the excretory or the degraded product of this heme, right? Degradation, right? It's the excreted product. So remember, guys, where this bilirubin is conjugated. Remember, it is conjugated in the liver to form bilirubin diglucuronide, right? And it is excreted in bile. It is excreted in bile. Now, guys, what is the blood bilirubin levels, guys? What is the blood serum? I'm talking about the blood bilirubin levels. The normal concentration of serum bilirubin is in the range of 0.2 to 1 milligram per deciliter, guys. Very, very important. Just try to mention or just try to learn this normal concentration of serum bilirubin, and that is approximately around 0.2 to 1.0 milligram per deciliter. Now, Remember, guys, we have already discussed the conjugated and the unconjugated bilirubin. So yes, the conjugated bilirubin, it is 0.2 to 0.4 milligram per deciliter, while the unconjugated one, guys, it is from 0.2 to 0.6 milligram per deciliter, right? So that is something that you have to remember. Now, you already know we have discussed about jaundice also yesterday, right? And we have already seen signs of no, the sclera becomes yellow, right, due to the deposition of these bilirubin pigments. Now, guys, there is something called as the icterus index. Now, this index, it is a simple test, guys, to measure the yellow color of the serum, right? Okay, the serum will appear yellow color due to the presence of these bilirubin pigments, and that is this yellow color. It is coming due to this bilirubin. So this is something called as the icterus index, right? Coming on to the next one, guys, that is we have already discussed in the protein metabolism also transaminase and aminotransferase, guys, right? We have discussed this in detail, guys, over there. These are the activities of two enzymes, guys, right? The serum glutamate pyruvate transaminase, the transamination reaction, guys, that we have discussed, right? So that is alanine transaminase, right? And serum glutamate oxaloacetate transaminase, right? So that is SGOT, aspartate transaminase, right? So we have SGPT, yes, and alanine transaminase, and we have SGOT and aspartate transaminase. So remember, guys, that ALT, it is found in the cytoplasm. So I can easily say that ALT is a cytoplasmic enzyme. So this ALT, it is basically found in the cytoplasm. Whereas, coming on to the AST wala part, Peter, remember it is found in both cytoplasm and mitochondria. The two important questions that you can see. Yes, so the ALT enzyme, the alanine transaminase, it is found in the cytoplasm. The AST, it is basically found in both cytoplasm and mitochondria. Now, remember, guys, in the normal blood, the activities of these enzymes are low, right? These enzymes are low in the blood levels, right? In the normal person like me and you, yeah, the healthy person, the adult human beings, right? These enzymes, the ALT and the AST, they are decreased, right? Normally. Now, whenever these ALT and AST will be increased, it is a sign that it is the liver is damaged. There is some sort of liver infection over here, and that is something which will indicate that there is some problem to the liver. Now, remember, guys, alanine transaminase is more sensitive and reliable, right? Remember, guys, that we have a ratio that is AST by ALT, and that is around 0.8. Okay. Now, remember, guys, ratio if the ratio aspartate transaminase by alanine transaminase, if it is more than 2, okay, if it is more than 2 in myocardial infarction, so this ratio can be more than 2 in myocardial infarction, where there is decreased blood supply to one portion of the heart, that is the myocardial infarction, right? Less oxygen supply to one part of the heart. Even in the alcoholic hepatitis, okay, the liver infection due to over um, no drinking of alcohol, right? The alcoholic hepatitis, and can there can be fibrosis of the liver parenchyma. That is something cirrhosis, the fatty liver disease, right? The cirrhosis of the liver, right? So that is something you have to remember. Normally, the AST by ALT ratio, it is 0.8. If it is more than 2, so it indicates so this ratio becomes more than 2 in several conditions, such as the myocardial infarction. Apart from that, we have the alcoholic hepatitis and cirrhosis. Okay. Now, if there is hepatocellular damage, this ratio will automatically decreased, and cholestasis, right? So that is you have to remember. Coming on to the next enzyme, that is alkaline phosphatase. Again, we have discussed this. Again, the very first question that is being asked in the exam, it is mainly derived from the bone and the liver, right? If the blood levels of ALP, if the blood levels of ALP are increased, so they are associated with elevated serum bilirubin, and guys, remember they are indicator of biliary obstruction, right? we have yesterday discussed that there are three types of jaundice: pre-hepatic, hepatic, and post-hepatic jaundice, right? So obviously, the obstructive jaundice where no, the bilirubin is not be able to secrete through the ducts, right? If the ducts are blocked, so that is something, the biliary ducts are blocked, and that is something which will lead to the increase in the level of the serum ALP, and it is indirectly related. It is related to the elevated serum bilirubin levels, right? Apart from that, it is also elevated in cirrhosis of the liver and hepatic tumors. All the cancers of the liver, guys, mostly the cancers of the liver, they are also, yeah, where this ALP will be increased. Alkaline phosphatase value will be much, much more increased, right? Coming on to the next one, guys, that is the gamma glutamyl transpeptide. So remember, it is a microsomal enzyme and it is like distributed in various parts of the body, and the main part, that is the liver. Okay, so that basically provides a sensitive index to assess the liver abnormality, right? So yes, see, it is just parallel to the enzyme which is the transaminase. So even if the transaminases are like more in the hepatic damage, so automatically this will be increased as well, right? Even this is highly elevated in biliary obstruction and alcoholism, right? Now 5-nucleotidase, guys, you already know it is this enzyme is elevated in hepatobiliary disease. Now the disease which is confined to the liver part and the biliary ducts, right? Apart from that, it is the other enzymes that you can remember, that is serum isocitrate dehydrogenase and isoenzymes of lactate dehydrogenase 4 and 5. We have the 5, 1, 1, 2, 3, 4, and 5. So 4 and 5 enzymes that are also like in the liver function test, right? So that is regarding the different enzymes in the liver function test, and that is how you have to proceed the question while you are writing the answer, and it is automatically a long question sometime, right? 5 or 10 marks. Now, coming on to the next question, guys, what is Van der Berg reaction? Remember, it is a specific reaction to identify the increase in serum bilirubin, right? Levels, right? So remember, it is basically, see, we have a reagent called as Vandenberg reagent. We have a reagent called as the Vandenberg reagent. And remember that reagent, it is basically a mixture of both sulfanilic acid and sodium nitrate, right? Now, what is the main principle of this reaction, guys? Diazotized sulfonuric acid reacts with this bilirubin to form a purple colored azobilirubin. No, if we just try to see this, right? If we are adding this Vanderburg solution, what will happen? So there will be direct detection of the bilirubin, and if there is addition of Vanderburg solution B, then there will be direct and indirect bilirubin. Both will be detected. Remember, guys, the direct and indirect reaction. What is actually meant by this, guys? The bilirubin, as such, it is insoluble in water, while the conjugated bilirubin is soluble, right? So remember, guys, the bilirubin, it is insoluble in water, while the conjugated bilirubin is soluble. Now, what happens? What happens, guys? This Van der Berg reagent reacts with the conjugated bilirubin and gives a purple color immediately, right? Obviously, guys, this conjugated bilirubin, if it is soluble in water, so this Van der Berg reaction will actually no react with this conjugated bilirubin and will give this purple color, okay, instantly, right? And that is a positive or a direct positive Van der Berg reaction, right? So positive Van der Berg reaction is when guys, when there is, yeah, you already know this Vandenberg reagent. Vandenberg reagent reacts with the conjugated bilirubin, and they give a purple color immediately, right? Now, even guys, if we are adding methanol, basically it dissolves the unconjugated bilirubin and it will give the Vandenberg reaction indirectly positive, guys. Indirectly positive. It's not just like direct reaction, right? Obviously, we are adding methanol that will dissolve the unconjugated bilirubin, and that is something you can remember, right? So guys, remember, if there is direct positive reaction, if there is direct positive reaction, it is an obstructive jaundice, right? If there is indirect positive reaction, it is an hemolytic jaundice. And if there is biphasic, both direct and indirect, that is hepatic jaundice, right? That is hepatic jaundice. So hepatic means the hepatic one, pre-hepatic the hemolytic one, and post-hepatic it is the obstructive jaundice, guys, right? Now, again, they have already explained this. If the serum contains both unconjugated and conjugated bilirubin in high concentration, the purple color is produced immediately, which is further intensified by the addition of alcohol, right? This type of reaction, it is known as biphasic, right? Now, that is something you have to remember about this. Coming on to the next one, the different types of jaundice. We have already discussed this, and we have to classify the jaundice based on the liver function test. So basically, we have the three types of jaundice, guys, that I am discussing from yesterday. We have the pre-hepatic jaundice, hepatic jaundice, and the post-hepatic jaundice. Now, what happens to the level of serum bilirubin? Remember, guys, the serum bilirubin in the hemolytic jaundice will be raised and it is mostly unconjugated. Hepatic jaundice, basically both the levels, right? The conjugated and the unconjugated, both will be increased, guys. Both will be increased. And obstructive jaundice, basically the post hepatic jaundice, it will be raised and it will be conjugated. Coming on to the next one, the alkaline phosphatase, guys. It is normal in prehepatic jaundice. A slight increase, or exactly I would say a normal part, or normal, guys, it will be in the hepatic part, and in the obstructive jaundice it will be increased. SgO2, basically it will be normal. SGPT also will be normal in hemolytic or prehepatic jaundice, where will be both the concern these enzymes, the SGOT, SGPT will be highly raised in the hepatic jaundice, right? Apart from that, if we compare to the obstructive one, they can be normal, guys, or there will be a slight increase in this the levels of this SGOT and SGPT. Yes, the PT time, that is the prothrombin time, will be normal, or it will be increased in cases of hepatic or the obstructive jaundice. The serum albumin levels, again, in the hemolytic jaundice, it is normal. Okay, the hepatic jaundice, it is low, and obviously the obstructive one, it will be normal. The stool color in the hemolytic, already know the hemolysis of the blood, it will be dark color. Hepatic jaundice, it will be normal or slightly pale, and in obstructive, it is pale, guys, right? That is based on the different levels, guys, right? The different blood chemistry parts that we have taken over here: the serum albumin, the alkaline phosphatase, the SGOT, SGPT, prothrombin time, the serum albumin, and the stool, right? So based on this, we can differentiate between the different types of jaundice, and we have already discussed this jaundice yesterday, guys, right? We have already discussed the jaundice part yesterday. Now, so guys, you can very well see. Let us start with the kidney function test. But before that, let us just discuss the basics about the kidney, guys. Let us just discuss the basic about the kidneys. So guys, when you already know the main structural functional unit of kidney, it is the nephron, and nephron basically starts from this glomerulus, right? So what this glomerulus do, it filters the small solutes from the blood. It filters the small solutes from the blood, and then it goes into the proximal convoluted tubule. Now what this PCT does, PCT is basically for the absorption of the ions. All the ions which are secreted by this glomerular part will be reabsorbed back into the PCT along with the both water and nutrients. Apart from that, this PCT will remove the toxins part. Okay. In addition, it will take the no, it will take iron, it will take the water and the nutrients, and what it will give in return, it will give all the toxins. And yeah. Coming on to the third one, guys, you already know we have the descending loop of the Henle. Loop of Henle has three parts: descending loop of Henle, right? Ascending loop of Henle. So remember, guys, yeah, the descending loop of Henle, basically there are aquaporins which allow water to pass from the filtrate into the interstitial fluid. Ascending loop of Henle, very, very important. It reabsorbs sodium and chlorine from the filtrate, right, into the interstitial fluid. Then we have the distal convoluted tubule, the DCT, right? It selectively secretes and absorbs different ions to maintain the blood pH and electrolyte balance. And lastly, it is the collecting duct, guys, which absorbs the solute and water from the filtrate. So that is the basic function that you already know from the physiology part. So coming on to the major functions of the kidneys, you already know it is the urine formation, guys, and main function it is the excretion of the waste products, right? Apart from that, guys, remember there is regulation of water and electrolyte balance. There is regulation of water and electrolyte balance, and there is regulation of acid-base balance also, right? And we have the hormonal functions, that is calcitriol, the vitamin D functions, the renin, erythropoietin, right? The erythropoietin secretion that is also done by the kidneys, right? Now, coming on to the different types of the RFT, yeah, the renal function test, RFT, or it is also known as the KFTs, guys, the kidney function test. Remember, guys, the types of RFT, there are the very first one, it is the clearance test. Now, when we see the clearance test, basically we measure the volume of the blood, okay, or the plasma completely cleared of a substance per minute. Okay, basically it compares the amount of substance which is present in the urine to its concentration in the blood, right? So that is basically done by a formula, that is C is equal to U into V by P. C is basically the clearance of the substance, right? So it is ml per minute, right? Then we have the concentration. U basically refers to the concentration of the substance in the urine. Apart from that, we have the V, that is the volume of urine passed per minute. Volume of urine passed per minute, right? And we have the P, that is the concentration of substance in the plasma. So that is how the clearance is calculated, right? So basically it measures the volume of blood completely cleared of a substance per minute. Okay. So yeah, coming on to the next part, that is the glomerular filtration rate. You already know it is 120 ml per minute, guys. Very, very important. The GFR, it is 120 ml per minute. And substance which are used for the clearance test in physiology also we teach. It is the endogenous, that is the creatinine, and the exogenous, that is urea and inulin. The urea and inulin, these two are again very important questions that you have to remember. Again, in the Viva or 1 mark question, they can simply ask you the endogenous substance used for clearance test. It is creatinine. The exogenous part, the substance which is used for clearance test, it is the urea and the inulin. Apart from that, guys, the creatinine clearance test basically measures the volume of the plasma completely cleared of creatinine per minute, right? Creatinine, guys, it is an ideal substance for KFT, right? As its values always remains constant. Oh, and the reference value that we use actually it is 75 ml per minute. So yes, we are taking the urinary creatinine, right? Obviously, in the last one, basically we have taken the concentration of substance in the urine, but over here we are taking the urinary creatinine as its value is almost constant. Then we have the plasma creatinine. Then we have the volume of the urine per minute. Now, urea clearance test, again, we can measure the volume of the plasma completely cleared of urea per minute. Again, same like the creatinine. Yeah, it is a metabolic product of amino acid metabolism. We have discussed in the urea cycle, right? We have discussed very clearly, I have shown you the urea cycle and how the urea is formed. So urea clearance values are expressed in two ways. Firstly, it is the maximum urea clearance and the standard urea clearance. Maximum urea clearance, it is if the urine volume is more than 2 ml per minute. If the urine volume it is more than 2 ml per minute, and standard urea clearance if the urine volume is less than 2 ml per minute, right? So remember it is approximately 54 ml per minute. The reference value it is 54 ml per minute. Now, guys, coming on to the tubular function, guys, you already know the tubules, the PCT, the DCTs, the loop of Henle, right? So we can do it by the two things, that is the measurement of the specific gravity, right? So it is the simplest test, guys, for the tubular function with a normal range of 1.012 to 1.024, right? And decrease in the specific gravity indicates tubular dysfunction. Apart from that, remember the measurement of volume of urine, the normal urine excretion, it is 1.5 liters per day. It's approximately 1.5 to 2. So increased volume may suggest tubular dysfunction, right? It may suggest tubular dysfunction. Coming on to the next one, that is the thyroid function test. Thyroid function test, guys, remember the two major hormones that are being produced by the thyroid gland. It is T4 and T3, right? We have the tetrahydrothyronin and the trihydrothyronin, right? Remember they are essential for the development, tissue differentiation, the genetic expression, and cellular metabolism in the every cell of the body, right? Now, guys, let us just try to see. This is something which we have already discussed, the thyroid hormone synthesis, right? From the tyrosine, if the iodination is taking place, then we have monoiodothyronin and diiodothyronin. If the coupling is taking place, then we have triiodothyronin and tetraiodothyronin. And obviously, that is how the T3 and T4 are formed. That is result due to a coupling. And how this mono and di are formed? They are formed by iodination of this, yes, amino acid. That is the tyrosine. That is the tyrosine. In tyrosine, if the iodination will take place, then we have this coupling. Then, yeah, T3 and T4. Hmm. Coming on to the next one, that is the abnormalities of the thyroid hormones. Very, very important. Remember, guys, the first thing, it is the hyperthyroidism, or it is also called as thyrotoxicosis. Now, guys, there is increased production of the thyroid hormones, right? There is increased production of T3 and T4. Remember, guys, there is high basal metabolic rate, right? There is weight loss, very, very important. In hyperthyroidism, you will have weight loss, nervousness, tachycardia, the heart rate will be more than 100. The heart rate will be more than 100. The irritability would be there, anxiety, heat sensitivity, and often protruding eyeball. Means your eyeballs will be coming out. That is something called as the exophthalmos, right? So that is the clinical features of this hyperthyroidism, guys. That is something referred to as thyrotoxicosis, right? That is. Hmm. Now, there are two types. We have primary and secondary hyperthyroidism. So hyperthyroidism, it is again divided into two types. We have primary and we have secondary. Primary hyperthyroidism and secondary hyperthyroidism, right? Primary, basically, we have thyroid diseases like Graves' disease, or we have goiter, the toxic goiter, right? And secondary, that is due to TSH secreting tumors in the pituitary gland. Now, what is this TSH? TSH basically stands for thyroid stimulating hormone, guys. Thyroid stimulating hormones. Thyroid stimulating hormones, and that is something being secreted in the pituitary gland. The TSH basically sends signals through the thyroid gland to further synthesize this T3 and T4. This TSH basically it comes from the pituitary gland, and which part of the pituitary? It is the anterior pituitary, guys. So that is guys. This secondary hyperthyroidism, it is basically due to THS secreting cancers, right? Cancers or tumors in the pituitary gland. Coming on to the hypothyroidism, guys, remember hypo means low, so there will be decreased production of the thyroid hormones. Obviously, the decreased metabolic weight rate will be there, weight gain will be more, right? Opposite, weight loss is a feature of hyperthyroidism, weight gain it is a feature of hypothyroidism. Constipation, bradycardia, obviously tachycardia was a feature of hyperthyroidism. Bradycardia, the heart rate is less than 60, 70, like that is bradycardia. Sluggishness, cold sensitivity. There was heat sensitivity. Over here we have cold sensitivity and neck puffiness. Again, the hypothyroidism, it is basically of two types, primary and secondary. Primary basically due to the factors like iodine deficiency or Hashimoto's syndrome, or if due to any part, there's surgical resection of the thyroid gland, obviously the thyroid hormones will be produced rest. And secondary basically are the disorders which affect the pituitary gland, right? And obviously if the pituitary gland, if this is the pituitary gland and if it is secreting TSH is low, automatically the hypothyroidism will be there, right? No, that is something you have to remember. The hypothalamus basically sends the signals to the anterior pituitary to release this TSH hormone, right? The thyroid stimulating hormone, and that will stimulate the thyroid gland, and it will release this T3, T4, and calcitonin. This three T3, T4, and calcitonin, right? This T3, T4, and calcitonin, right? So that is you have to remember. Coming on to the next one, that is the thyroid function test, guys. The thyroid function test. So remember, it's a test to evaluate the thyroid gland function. It's a test to evaluate the thyroid gland function. So various thyroid disorders and like they're basically used to diagnose, right? So let us just try to discuss something very okay. We have already discussed these thyroid glands, but let us just try to see what is like the main thyroid function test over here. So yes, let us first try to discuss in on our own way, right? This is a very important question. This is a very important question. Now, what are the investigations, guys? Investigations in thyroid disorders. In thyroid disorders. Remember the very first investigation, there are many, guys. The very first investigation, guys, that we do over here, it is actually the thyroid function test. The thyroid function test, that is we check the levels of T3, T4, and TSH. Then we also check the free levels of T3 and T4, and then we also check anti-thyroid antibody test. Anti-thyroid antibody. So that is the first investigation. That is the thyroid function test, and we are checking these levels. Now remember, guys, if the TSH it is increased, remember it is hypothyroidism. If TSH it is low, yes, that is the hyperthyroidism, guys. That is hyperthyroidism, right? Apart from that, we can do the ultrasound of the neck. There are multiple no patients suffering or patients having features of hyperthyroidism. We always try to do the ultrasound of the neck, right? If we don't do the ultrasound, there is something called as the thyroid scan. The thyroid scan, and basically it actually tells about the gland enlargement. Okay, what is the nodularity, what is the blood vascularity, blood supply, or the lymph nodes. So that thyroid scan is also very important. We have these thyroid scans also, right? We have the thyroid scans also, right? We have the thyroid scans, and you already know these thyroid scans are um, basically they are telling about the gland enlargement. The gland enlargement in case of hypothyroidism, there is nodularity, vascularity, and the lymph nodes, right? Or there is something called as FNAC. FNAC basically stands for fine needle aspiration cytology, right? We do a fine needle aspiration cytology, and that is investigation of choice, guys, for these thyroid disorders. But the one problem with FNAC, it cannot differentiate between the two cancers, right? The follicular carcinoma and follicular adenoma. So that is nothing that you have to like see over here. But these things are very important. So let us just discuss what is like given over here. So remember, guys, very first one, I always told you the first investigation that we do, we measure the T3, T4, and TSH levels, right? Remember, guys, the primary hyperthyroidism. If we talk about hyperthyroidism, remember, if it is primary, guys, T3, T4, both the levels will increase, right? And TSH will decrease, right? If it is secondary hyperthyroidism, TSH, T3, T4, all levels will increase, right? All levels will increase. So that is how to differentiate between primary hyperthyroidism and secondary. Obviously, secondary hyperthyroidism, I told you it is due to the over secretion of the TSH. So obviously the TSH levels will be very much more. The TSH levels will be very much more because it's referring to the no tumors of those yeah, the anterior pituitary, which will be secreting this TSH. And obviously, if TSH is more, T3 automatically will be more over here. In primary, coming on to the primary hypothyroidism, hypothyroidism. And remember, guys, in hypothyroidism, again, we have primary and secondary. The primary, that is T3, T4, both will decrease, and TSH will increase. In secondary hypothyroidism, T3, T4, TSH all will decrease. Obviously, if there is surgical resection of the thyroid gland, or if there is uh, any other disorder where the TSH production is decreased, automatically the T3, T4 production will decrease, right? The normal serum values, again, the free T3, it is 80 to 20 nanogram per deciliter, and TSH should be less than 10 microunits per ml. So that is something that you have to remember, guys. The flowchart that is over here in hypothyroidism, guys. Remember the levels of T4 will be increased. The T3 uptake will be increased. The radioactive iodine uptake, basically, it is increased in Graves' disease, right? The free thyroxine index will be increased, and remember the thyroid stimulating hormone will be decreased. Hyperthyroidism, I've already told you the primary hyperthyroidism, right? And if it is like high thyroid binding globulin, obviously the levels of T4 will be increased, but T3 uptake will be decreased because it is already binded, guys, and the other values basically remain normal. Hypothyroidism, the T4 levels will be decreased. Yes, the T3 uptake will be decreased. The radioactive iodine uptake decreased. Free thyroxine index decreased, and TSH will be increased. Obviously, TSH is functioning normally, but the T3, T4, they are not formed, right? So the low thyroid binding globulin, basically what happens, the T4 is decreased, the T3 uptake, it is increased, guys, whereas all the levels remain normal. So that is the thyroid toxicities, right? Guys, you can very well see, yeah. um, yes, the multi nodular goiter, right? So basically, this is the abnormalities in the thyroid scan, right? So basically, remember, guys, that these thyroid scan. Now, whenever we talk about thyroid scan, guys, remember this thyroid scan, basically it can be done by technetium 99 and iodine 123, right? So it is a technetium 99 scan or iodine 123 scan. Remember, guys, technetium 99 scan basically only tells about the uptake of iodine, right? Whereas basically iodine 123, basically it will take the it will tell the uptake and organization of this iodine, guys. Now, whenever we know do this thyroid scan, it is basically no, why the what are the indications, guys, why we need to carry out a thyroid scan? If there are features of hyperthyroidism, if there are features of hyperthyroidism, and remember it, if it is low TSH, then in that case, or if you find this thyroid gland somewhere else, so we can have the ectopic or a thyroid gland which is not functional, aberrant thyroid tissue, thyroid tissue. So that is something that you have to remember, guys. The normal uptake you can very well see. Yeah, both the thyroid glands are very much visible, right? We have the cold nodules and the hot nodules, right? So that is something you have to remember. Yeah. Cold nodule basically means all the iodine is basically taken up by the gland, but there is one nodule which has not taken up the iodine. So nodule, basically it is the non-functioning nodule that is actually called as the cold nodule. And there is something called as hot nodule, guys. The gland is suppressed. Okay. All the iodine is taken up by the one nodule, and that is something which is called as the hot or the hyper functioning nodule, right? So you can very well see in Graves disease, guys, there is diffused or increased uptake. If you can see, if we compare with the normal part, there is diffused or increased uptake, guys. There is diffused or increased uptake, guys. That is something you have to remember. If we have thyroiditis, guys, obviously there is decreased uptake. So you can very well see, if we compare with the normal, we have the decreased, diffuse, decreased uptake, right? Or we have the toxic multinodular goiter, guys. Remember, guys, it is also the pulmonary plumber's disease, right? The plumber's disease over here, right? So that is something you have to remember. You can just see the nodule formation over here. That is again you have to remember, right? So that is the thyroid uptake studies. Basically, I have already told you the radioactive iodine, right? So basically, it assess the thyroid function. So iodine, yeah, 123 or 131. I don't know. Yeah, it can be 123. Yeah, 131 can be also be there, right? So normal value, it is 25% uptake within 2 hours and 50% uptake within 24 hours. So hyperthyroidism, increased uptake, hypothyroidism, decreased uptake, right? That have we already discussed. Thyroid scanning, yes, yes, 131. Yeah, the iodine, yes, the iodine 131. So increased radioactivity indicates darkly shaded areas in hyperthyroidism. We have already discussed this. And defective, this will result in thyroid cancer. Now, thyroid antibodies, I have already discussed in the starting. So it identifies the specific antibodies such as anti-TPO antibodies, right? In Graves' disease, we have the thyroid stimulating immunoglobulins. The LATs mimicking TSH are found. Hashimoto's thyroiditis, we have anti-thyroglobulin, anti-microsomal, and anti-nuclear antibodies are detected. Again, very, very important. You have to remember in Hashimoto's thyroiditis, anti-thyroglobulin, anti-microsomal, and anti-nuclear antibodies are detected. Now, again, there are miscellaneous test, guys, that you can just remember. These are just for historical importance, right? The TRH response test. Then we have T3 resin uptake test, serum cholesterol levels, and measurement of BMR and serum CPK, creatinine phosphokinase, right? So it is not routinely done as of now. Apart from that, the serum cholesterol levels, they are almost elevated in hypothyroidism, guys. Yes, a patient who is suffering from hypothyroidism, always they will have no, these cholesterol levels would be increased. Again, the T3 resin uptake measures the free binding site on the thyroid binding globulin. So in hyperthyroidism, we have a low free binding site on thyroid binding globulin. And TRH response test, basically it measures the T3 and T4 levels after administering thyroid tropin releasing hormone, right? So it is the negative feedback which affects the T4 override. We have just seen the diagram also. There was TRH over there, right? So in hypothyroidism, there is no response in secondary part, right? The secondary hypothyroidism. That is all about today. So these are the social media handles which you can just follow for the upcoming classes, right? You can just go through it. Thank you. Thank you.